Hello, this is Elena Coucher. I will be presenting chronic illness, disability, and end-of-life care. We're going over chapters 36 and 37 out of your text. So let's talk about children with chronic or complex diseases. The scope of the problem, there's increasing viability of preterm infants. We're keeping them alive at even younger times, born at 23 weeks, 22 weeks, where we're getting them to the age where they are able to discharge home, but they go home with chronic conditions, living at home on oxygen. Portability of life-sustaining technology, such as being home on portable oxygen, life-extending treatments, rise in the number of children with complex and chronic diseases. And, advances in medicine have increased the morbidity of children. The trends in care, developmental focus, family-centered care, family health care provider communication, establishing a therapeutic relationship, the role of culture, shared decision-making, and normalization. Trends in care focus on involving the family in all the decisions and allowing them to make the final end-of-life decision. The family is the constant in the child's life. They may have to repeat information over and over for the family to process that information and assimilate it. We need to allow them to repeat questions and requests for clarification and more information. Be open, honest, and again, culturally sensitive. I've already talked to you about being culturally aware. We need to be culturally sensitive, and we need to communicate effectively with cultural sensitivity, because this helps to foster a therapeutic relationship between the family and the healthcare professionals, and it results in shared decisions that are best for the child and the family. So how does the child's chronic illness or disability affect the family unit? The parents are looking at the parental roles. They require additional responsibilities that they're going to have to be balanced out with daily family needs. What if there's other children? Mother and father differences, different coping mechanisms. The mother, she might be more likely to quit the job, and so consequently she's going to deal with some social isolation, and she's going to need some social support. Fathers do not know how to protect their children, and they may be the main breadwinner of the home. They feel powerless, may lose self and work to avoid thinking about it. And then, of course, single-parent families, you can just imagine the financial and time burdens that they experience. And with siblings, information and knowledge regarding the illness is important. Imagination may be the worst. And I'm going to tell you a story real quick. Just because y'all don't get to hear these very often with us doing these on YouTube. But my oldest daughter, suffered a traumatic head injury in a car accident when she was 7 years old. And she was in the hospital for 6 weeks. She was in critical condition. You probably don't know what this is just yet, but she had a Glasgow Coma scale of 8 when she arrived at the hospital. She had a depressed left temporal skull fracture and had massive hemorrhaging on her brain. So, I was pregnant, and her younger sister was 5 at the time, and she was in the car accident with us, and all she saw was her sister unconscious. And we did not bring her up to the hospital to see her sister in ICU for fear that it would upset her. But in the long run, we ended up upsetting her more because she thought her sister had died. So you really have to think about the siblings and make sure that we encourage the parents to tell the brother and sister as much as possible about what's going on with the child. There's concurrent stresses within the family. The coping mechanisms are going to be behaviors are going to be aimed at reducing the tension. Stress of chronic illness may compound those stressors that are already present. If they're already having financial difficulty, if they have a chronic illness, it's just going to make it even worse. Financial stressors, even if they have a good income and good insurance, is possible. The parental empowerment, we want to be able to have them recognize, promote, and enhance their competence in taking care of their children. Shock and denial, that's the initial response to a diagnosis of chronic illness or traumatic diagnosis. Denial is a common reaction to any tragic event. It can last days to months, and maybe it lasts even longer. On page 1057, there is a list of denial behaviors if you want to look at that. Denial allows a child to maintain hope. Denial is misunderstood and treated inappropriately by healthcare providers, and denial only becomes maladaptive if it delays the treatment. The adjustment follows shock and denial. They may have guilt and self-accusation due to the belief the illness was from something the parent did, a test from God for some previous transgression, or a child believes due to misbehavior. Anger is common from both the child and the family. It's often misplaced on the nursing staff. The well child may be angry for the attention paid to the ill child. And parent reactions influence child's response to illness, overprotection, rejection, denial, and gradual acceptance. And an adjustment, talking about how the well sibling may react to everybody being all about the ill child. My pediatrician, she does it's called the Glass Children is what she calls it. And it's a program that they have at their church where once a month they get together and they take care of the disabled children so that the well children can go out, because typically what they see is that and that's why they call this the Glass Children program, because the well child is looked right through to the sick child or the one who has a disability, and strangers and family alike look straight through that well child to the sick child. And so the Glass Child program enables these parents and the well children to go out and have a moment where it is just them and no one's looking through the well child to see the other one. Reintegration and acknowledgement is a large part of this stage of grief. They could have chronic sorrow. Establishing a support system. We have to assess families for risk of succumbing to crisis. They need support systems, family, friends, church group, community resources, and parent-professional partnerships. Developmental effects of chronic illness. It goes by age groups. I'm not going to go into it, but if you'd like to look at it, it is Table 36-1 on pages 1060 to 61. Coping mechanisms. There's 5 distinct patterns of coping. Hopefulness. Hope gives reason to continue on, and health education promotes the coping. So when we're assessing, we have to assess how the family handles stress, their financial, the marital, the career, etc. In the past, it helps ID families with less ability to cope. So if they weren't coping very well before, then how do you think they're going to cope after? Family members' reactions to the child's illness and the needs of parents and siblings. I had a grandbaby that was born IUGR, intrauterine growth restriction, and I can see some of this and through this. He's not a chronically ill child, probably just in our heads. He's actually been progressing just fine. He's still a little bit delayed in growth on the growth chart, but he was just so sick, and he's had periodic times of being so sick, and he's had to have surgery, and so everyone tends to we tend to kind of hone in on him, and we're scared to let him do anything, while we'll let the older one that's 3 do jump off the bed. We don't want Oliver jumping off the bed. So this is how we have reacted to him being IUGR and still being so small and what we feel like is fragile. And we have to look at the needs of the parents and siblings. For example, and I'm using my family a lot here, but my son-in-law, they have a second child now, and he is just really attached to this second child. That is his boy now. And I don't think it's not because he loves Elliot more than Oliver. It's simply that Oliver scared him. He was so tiny. He was, just a little bit bigger than Kevin's hand when he was born. He was tiny, and it's just he was just always so scared to handle him. So again, you can look at my family and me talking about this, and you can see how to assess a family like us, who we're reacting to this child who is born into this world in such a tiny little body, and it's taken a long time to even try to get caught up. Providing support at the time of diagnosis. We want to encourage parents to be together when diagnosis is given. We want to assist in interpretation issues, emotional support for each other. They need private, uninterrupted area, and they need to be allowed to show their emotions. Parents, be attentive to families. Communication is essential. Discuss feelings and impact the illness. Be sure to include the fathers. The parent-to-parent support. There are support groups, I've already said that you can go to a support group of people that are just like you, and if you can sit in that group and hash out your feelings, you realize that there's other people that feel the same way that you do, and it feels good to be in a group of like-minded folks. Advocating for empowerment. We want to encourage parent membership on committees that affect their child and legislation. I have a good friend of mine at church who had triplets. Her babies were in the NICU at Children's Hospital for 3 months. She now sits on the advisory board. The affected child, focus on a positive self-image. What about makeup or wig? Get them out of their room or house as the illness permits. And the siblings really may get less attention from the parents during the sibling's illness. May cause negative attitudes towards their ill child. Perhaps a sibling support group would be beneficial. The nurse should use anticipatory guidance to avoid any negative effects on the family. Educating about the disorder in general health care. What about activities of daily living? There's possible differences in nutritional requirements. They'll need guidance for that. Safe transportation. They may have to have modification for car safety. And primary health care. They'll need all the usual health care, and who do they need to communicate with? What physician in an emergency do they need to contact? Also, you may have to look at what about medical alert or jewelry or some type of card that lets people know. What if they have an ill child that they're transporting somewhere and there was a car accident? Then there needs to be some kind of alert on board that lets medical professionals know what is going on with this baby. Promoting normal development, early childhood. There's basic trust. We want to encourage self-care as much as possible. The goal is to achieve separation and independence in the early childhoods. Parents tend to be overprotective of the sick child, and we want to help the parents avoid overprotection. Y'all could probably counsel with me and my family about overprotecting Oliver. Characteristics of parental overprotection are in box 36-7 on page 1067. Also need discipline. Helps children feel safe and learn socially acceptable behavior. Also, lack of discipline for sick children can cause resentment and hostility from the other children. At school age, there's missing school delays and progression. They need to resume school as soon as possible. May start with the hospital or a homeschool until they're ready to go back to school. Child needs to be prepared as well as prepare the other children before as to what to expect. In adolescence, we want to encourage them to take responsibility for their own behavior, make decisions for their own life, and maintain supportive relationships. Assist in their care plan, and participation in groups can help alleviate loneliness, isolation, and depression. We have to reestablish or establish realistic future goals. We have to cultivate realistic vocations for the child with chronic illness or disabilities. I have an Asperger kid, and so, as I was trying to prepare him for going out into the real world and trying to prepare him for college, I mean, I had to do so much research in order to find a career that he could hone his own abilities and have his comfort level in there. Um, and college didn't work for him. He's now in a trade where my husband works, and the reason why that it was a good place for him, and I had to realize this, was because even though he had never been there, it was a sense of comfort for him. So that's why I'm saying, like, cultivate those realistic vocations for the child. If the child says they want to be an attorney and they their cognitive ability is I don't want to say subpar, but not on point to be an attorney, we want to try to gear them and guide them in a direction and look at what skills that they could possibly do. Prolonged survival leads to new decision and problems such as independent living, marriage, employment, insurance coverage, and reproductive decisions. So when we're talking about children at the end of life, what are we going to do to take care of them? Palliative care is the absence of possible cure. So their primary focus is symptom control, supportive care, and quality of life, not curing or prolonging the life. It's established early introductory of the disease, does not hasten death, but provides pain and symptom control. The child and family are considered a unit of care. Multidisciplinary group equals the social worker, chaplain, nurses, aides, nurses, healthcare providers, such as the MD, APRN, or physician assistant. It can take place in the hospital or the home. The environment is home-like as possible. End-of-life care is part of the palliative care. The decision-making, multiple variables are looked at in the decision concerning care. Age, premorbid cognitive or functional status, pain or discomfort, probability of survival, and quality of life. Parents and healthcare providers decide when care should shift from curative to palliative, such with DNR and comfort care. And it's up to us, the nurse, to find out the family's wishes. We need to know. Withholding treatment is not euthanasia or assisted suicide. The dying child needs honest, accurate information about their illness, prognosis, and treatment, and we need to do it in clear, simple language. Sorry, I think I skipped forward just too many there. All right, so treatment options for the terminally ill child. We have the hospital, we have home care, we have hospice. The hospital, of course, the setting should be as home-like as possible. We want them to bring blankets from home, pillows from home, hang up pictures that are drawn from them, maybe from their Sunday school class, friends that write letters. Home should have home health care. And hospice, the healthcare organization, they assist, the dying patients and family in the natural process. It is a multidisciplinary group. It is different from hospital care, though. Family principal, caregiver with support of the team of the professional and the volunteer staff. The priority for the patient is comfort. Family needs equally as important as the patient's, and it helps with the post-death adjustment. The goal, live life to the fullest without pain, with choices of dignity in a familiar environment, such as the home, and with support of the family. Allows the child to be surrounded by people important to them and provides security. Siblings are more involved and the family is more comfortable. Allows the child to be admitted to the hospital if they have to be to die. They may not wish the child to die in the home. They may not want that memory within their home setting. Of course, my husband's grandmother is certainly not a child, but talking about the same thing for end-of-life care. We were the primary caregivers for her through the hospice. Probably one of the most, I don't know how I would feel about a child dying at home, but I think that I would much rather them be at home surrounded by as many family as possible. But that's just my way of thinking. But I feel like the hospice is such an important tool for the family to utilize. They're the most wonderful caring nurses that come and take care of your family members. All right, so fear of pain and suffering, that's very real. Pain and symptom management is the highest priority. Children experience pain no matter how young. Infants do. Some people, even nurses, do not realize how much pain is related to their way of dealing with pain. Pain meds should be given on a regular schedule with medication available for breakthrough pain. We do not worry about addiction. May need high doses of opioids to control the pain. There is no maximum amount. Some nurses are afraid high doses of opioids will accelerate death. And morphine is one that we use a lot, along with non-pharmacologic interventions like distraction, guided imagery. Other symptoms are aggressively managed. Parents and siblings need a good amount of support. Need teaching about pain control, especially if the child is dying at home. Provide empowerment and relief that the child will not be in pain or suffer. The siblings may feel isolated or displaced while the parents are spending a lot of time with that dying child. They may feel resentful, then guilt for feeling resentful. Nurses should help the parent incorporate siblings into care and take time out to spend with them. Child's fear of dying alone or parents' fear of not being present at the time of child's death, so they'll have a death vigil, can be exhausting for the family. Help arrange other family and friends to relieve the parents for rest. Hospice does help for that. Parents will want to be notified by phone of any change. We want to advocate for the parents to receive food and drink and comfortable chairs at their dying child's bedside. Fear of actual death they may prefer home death surrounded by the familiar, loved people, pets, and possessions. It may be distressful related to the child becoming less responsive. The nurse can help parents know what to expect in the end. Chain stokes, respirations, those can be distressing to parents. Opioids, the morphine eases those labored respirations. The death rattle, it's noisy respirations. Scopolamine may help reduce that noise because it reduces it related to noise maybe from the overhydration, so it'll dry it up. Place of death. Home will have to be pronounced, they'll have to be pronounced dead at home. Hospice helps with smooth transition. Excuse me. Hey, I'm sorry. Police may have to be notified to prevent concern of abuse. In the hospital, attend to the child's and the family's comfort. If death from an accident or acute illness, life support may have to be withdrawn. Parents will need detailed information and emotional support. Privacy, soft music, lowered lights, monitor sounds. Religious rituals may be needed to be performed. After death, remove all tubes and equipment. Allow the family to remain with the child as long as they want or need. They can hold, they can rock, they can bathe and dress if desired. They need to let their rituals be performed, and then the funeral home can be notified. Organ and tissue donation and autopsy. Meaningfulness of acting to benefit another human. It may feel good to them. I'm sure that some of you have seen those videos where a mother has donated her child's heart to another recipient, and then they meet sometime later and she gets to listen to that heartbeat again. Makes me cry every time I see them. Nurses need to know which children are candidates. Healthy child experiencing sudden death, and which are not cancer or prolonged illness for tissue donation or organ donation. It may be hard to discuss organ or tissue donation with parents. Some hospitals may have a transplant coordinator, though, that'll talk to the parents, so that's something that a lot of us have to worry about. Topics should be discussed before death. Once death is imminent, some states have a law that requests for organ tissue donation to be discussed. We have to have a signed consent from parents for organ or tissue harvest to proceed. Grief and mourning. Grief is a process. It manifests in physiologic, psychologic, behavioral, social, and spiritual reactions. It's highly individualized. Everyone experiences and deals with grief differently. Anticipatory grief, the grief reactions are a normal part of the grief process. Um, they start to grieve. I'll give you, for instance, my daughter was 5 years old. It was before I had that accident, and my stepfather, her poppy, passed away. But he had been sick for a while and at home on hospice care, and she grieved his death before it actually got there. She had anticipatory grief so that when he did pass, she had already moved through her grieving process. I know it sounds weird. She was 5 years old, and that's how she did it. The mourning process is different for everyone. Sometimes creates conflict within the family as family members perceive the other is not feeling and grieving the way they are. Nurses can help the family realize everyone grieves differently and support each member in their individual process. I probably go through the mourning process different than other people. My family and I, we tend to think about the fun times, and we laugh about the fun times and the things that we did with that person. So, and some of us may look at us in during visitation at the funeral home and think, why are they laughing? Well, because we loved our loved one, and we had such a good time with them, and we just remember the fun times. We don't want to remember the sad times right now. So everybody does go through it differently. Grief is recognition of when grief becomes complicated or abnormal is something that we have to know. Um, there's parental grief, sibling grief, nurses' reaction to caring for the dying children. Complicated grief, reactions more than 1 year later. Intense, intrusive thoughts, pangs of severe emotion, distressing yearnings, feelings of excessive loneliness and emptiness, unusual sleep disturbance, maladaptive levels of loss of interest in personal activities. They're going to need a referral to a grief counselor. Parental grief is the most intense, complex, long-lasting, and fluctuating grief experience compared with that of other bereaved individuals. Loss of hopes and dreams for that child's future, sometimes loss of spousal support. They may feel guilty when they resume life or feel joy. My mother still suffers from grief. My brother was born in 1968. She has what I would call abnormal grief at this point. I understand parental grief is a very intense form, but every year at the time that it would be his birthday, up until he died a month after he was born. So she will spend her time calling people and discussing his birth and his sickness and his death for that full entire month, and she will cry for that full entire month. She was never referred to a counselor, and I feel like that many times she should have been. Sibling grief is different from an adult, depends on the age, developmental level, and understanding of death. Children grieve for a longer duration. They revisit their grief as they grow and develop new understanding of death. It can be emotional one minute and off-playing the next. They may be aware of the parents grieving and try to be the perfect child. May exhibit adult reactions, physical sensations, and illnesses. Anger, guilt, sadness, loneliness, withdrawal, acting out, sleep disturbances, isolation, and search for meaning. The nurse's reaction, we have to listen to families, provide acceptance, understanding, and respect for this grief. Grief may last a good while. We need to refer people to support groups or grief counseling if it becomes prolonged or complicated. The nurses, we have to take care of ourselves as well. Time off, we have to have good physical health, professional and personal support system, focus on positive aspects of the caregiver role, and attending the funeral can be good for the family and the nurse. So now we're going to talk about the impact of cognitive and sensory impairment on the child and the family. Cognitive impairment is any type of mental difficulty or deficiency, intellectual disability, mental retardation. We've heard these terms. Diagnosis, suspicion by family or health professionals. They'll have developmental screenings during routine well child checkups and possibly made at birth. It consists of 3 components: intellectual functioning, sub-average, functional strengths and weaknesses, and younger than age 18 at the time of diagnosis. For instance, my son was diagnosed with Asperger's when he was 12, going on 13 years old. And I kept asking myself what was off. There was something that was wrong. I don't know why he's not understanding. I don't know why he's not forming normal relationships. And I mean, we went through so much. And I actually had a former student that came to church with my daughter one time, and she was a student at the time though when she came, and she visited the church with my daughter. She met my son, and she stopped by my office about a week later and knocked on my door. And I'd had a particularly rough weekend. I'd been crying. I dried up my tears, and I opened the door, and she said, "Hey, I can't, Miss Coucher, is there, what's going on?" I said, "Oh, nothing, I'm fine." She says, "No, Miss Coucher, something's going on." And so then she says, "Is it Sam?" Yeah, actually it is. I mean, I'm not going to lie at this point in time. I just lied, and I shouldn't have when I said everything was fine. And she said, "Have you ever looked at Asperger's?" And I immediately went on the defensive and said, "My son does not have any type of autism." But I started doing some reading, and I was like, "That's my son. That's my son. That's my son. That's my son." So, and it's a grieving process that you go through afterwards, and we'll talk a little bit about that. But sometimes you don't see some of the you don't see the forest for the trees, and I was one of those parents. I wasn't seeing the forest for the trees. So in functional impairments, adaptive skill areas, communication, uh, they must demonstrate functional impairment of at least 2 of these 10. So communication, home living, community use, leisure, health and safety, self-care, social skills, academics, work, and self-direction. The cognitive impairment classification. Results of standardized tests are used in making a diagnosis of cognitive impairment. 85% of the population with cognitive impairment are diagnosed as mildly impaired. 10% of the population with cognitive impairment are diagnosed as moderately impaired. They're trainable. Severe, their IQs are very low, and profound, extremely low. Why? Why does it happen? Um, may not be known. However, there's primarily genetic, biochemical, and infectious. I did read a research study some years ago through my BSN that children who suffered some type of trauma in the intrauterine environment are at risk of developing signs or ADD, ADHD, cognitive impairment, autism, and it listed all these things. And I was like, wow, I had my car accident when I was 5.5 months pregnant with my son, and he slammed pretty hard into my bladder. He was jerked all around. We tangled y'all with a tractor trailer rig. So you can imagine the insult that my children's bodies took. And so I've always wondered if that could have been the reason why. So some of the causes that possibly trauma, intrauterine infection, intoxication, the trauma, prenatal, perinatal, postnatal, metabolic or endocrine disorders, inadequate nutrition, postnatal brain disease, unknown prenatal influences, chromosomal anomalies, prematurity, low birth weight, postmaturity, psychiatric disorders with onset in childhood, and environmental influences. We have to educate the child and family with early intervention. A program of therapy, exercises, and activities are needed to address developmental delays. Be mindful that their pace of development is slower. Motivation has a tremendous impact on education for the cognitively impaired individuals. We want to teach the child self-care skills. They learn by habit formation, routine, repetition, relaxation. Skills such as feeding, toileting, dressing, and grooming that are usually easy for a child of average intelligence may be difficult for these children to achieve. Any progress that has been made at home should not be allowed to slip during any hospitalizations. We want to promote optimal development, more than achieving independence. Includes acceptable social behavior, personal feelings of self-worth, esteem, and security. Situations become more complicated as a child develops physically, but still requires constant supervision. For play and exercise, exposed to multiple types of stimulation. Sights, sounds, tactile. Toys should be educational as well as recreational. Major consideration in selecting activities is safety. Nurses should familiarize families with community resources, such as Easter seals. So when we're providing care, nursing care for the children with impaired cognitive function, we want to provide means of communication, speech therapy, picture boards, other means of communication. Establish discipline. Start early. Set firm, consistent limits on behavior. Reinforce desired behaviors. Encourage socialization. Same socialization needs as other children. Encourage acceptable social behavior. Hello, please, thank you, yes ma'am, no ma'am, yes sir, no sir. They need peer experiences, clubs, sports, such as Scouts or Special Olympics. We want to provide information on sexuality, and we have to teach acceptable sexual behavior. Contraception is definitely going to be advisable. Gear sex education to the developmental level. Protect against sexual abuse. Help families adjust to future care. Older parents may need to place their children, nurses should know community resources for that, in programs and residential places. Care for the child during hospitalization. Encourage the parents to stay with their child, but not a requirement, but we certainly want to encourage it. Try to maintain routine and preferences as much as possible. Assess cognitive level and explain procedures accordingly. Focus on growth-promoting experiences. PT, OT, social services may help. Some measures to prevent cognitive impairment. Counseling and education regarding nutrition and tobacco use. Adequate prenatal care needs to be provided. We want them to, we're having this and just had this in antepartum. We need our mamas to have the right nutrition. We need our mamas to quit smoking. We need our mamas to quit drinking. Awareness of dangers of chemicals. Teratogens are in the prenatal period, especially during the first 8 weeks during organogenesis, they're bad. You're going to have a child that can be cognitively impaired or have some other disability. Rubella immunizations, genetic counseling, and prenatal screening. Information on folic acid supplementation to prevent any neural tube defects. Many of these programs are available at our local health units. Okay, so Down syndrome is the most common chromosome abnormality. There's 1 per 691 to 1,000 live births that are born as a Down syndrome baby. Causes are unknown, as probably multiple. It occurs in populations of all races. It's non-familial trisomy 21. They'll get an extra chromosome 21 in 95% of the cases. Translocation of chromosomes, 15 in either 21 or 22 in 3 to 4% of cases. And mosaicism, a mixture of abnormal and normal cells in 1 to 2% of the cases. Maternal age places the fetus at risk. Age 35 is a risk is 1 per 350. Age 40 risk is 1 per 100 births. Diagnostic evaluation. They have separated sagittal sutures, square head with upward slant to the eyes, flat nasal bridge, protruding tongue, transverse palmar creases, wide space between big and second toes, and hypotonia. Chromosome analysis should be done to confirm these clinical findings. We can sometimes look at a child and think, oh, they look like a Down baby, but they're not. It may be just, it could be their genetic makeup, how mom and dad look. Common physical problems, congenital heart disease, respiratory tract infections, because of hypertonicity of the chest and abdominal muscles and dysfunctioning immune system. hypothyroidism, and leukemia. Therapeutic management. Available therapies: surgery to correct congenital anomalies of the heart, evaluation of hearing and sight. They may need glasses and or hearing aids as needed. Periodic testing of thyroid function and meds as needed. Supporting the child's family at the time of diagnosis. The parents may be in a state of grief because they were expecting a perfect baby. They may or might not know before they give birth, so it could be a shock if they did not know. You have to provide information and community resources, and that would be a good resource would be the National Down Syndrome Society. Prevention of physical problems. They have decreased muscle tone. It makes holding difficult, causes respiratory issues, decreased GI motility, and constipation. Underdeveloped nasal bone. So problems with clearing their nasal passages, causes mouth bleeding, drying oral mucosa, and it interferes with feeding. The protruding tongue, it interferes with feeding. It's not because their tongue is too big either. Protruding tongue is because of the muscle tone. Prenatal diagnosis may be made through amniocentesis if suspected by labs or ultrasound. And we're going to do genetic counseling if it's an older mom or there's a family history. So, Fragile X syndrome, most common inherited cause of cognitive impairment. Second most common genetic cause of cognitive impairment after Down syndrome. 1 per 3,600 boys and 1 per 4,000 to 6,000 girls. Is caused by an abnormal gene on the lower end of the long arm of the X chromosome. You'll see the pictures, guys, in my slides, but I've taken the pictures out of your slides. I think that makes it easier for you when you're printing. Fragile X syndrome clinical manifestations. They have large head circumference, long face with a prominent jaw, large protruding ears, large testes, postpubertal. Manifestations variable in female carriers of the gene. Flat feet, seizures in about 10% of those patients. Hypotonia, so they have a low muscle tone as well. Experience mitral valve prolapse, pectus excavatum, the indentation of the chest. They have hyperextensible joints, highly arched palate, large prominent ears, broad forehead, but they're normal structure. They have mild to severe cognitive impairment, delayed speech and language, hyperactivity, hypersensitivity to taste, sounds, and touch, autistic-like behaviors, and aggressive. They are intolerant to changes in their routine. And their autistic-like behaviors is because they will exhibit social anxiety and gaze aversion. Therapeutic management, Tegretol and Prozac for behavior control. They have a normal lifespan. There is no cure, though. They'll stimulants for hyperactivity, similar to management of attention deficit, ADHD. Referral to early intervention programs, speech, OT, special education, medical assessment of physical anomalies. Genetic counseling necessary related to hereditary and may affect males and or females in the family. We want to refer them to the National Fragile X Foundation or some other community resources. Hearing impairment, 1 in 6 per 1,000 healthy full-term infants, 2 to 4 per 100 premature infants. It can be slight to moderately severe residual hearing with the use of an aid. They could have severe to profound hearing loss, and they can't process linguistic information. Classified according to etiology, pathology, or symptom severity. The classifications are important in determining treatment, possible prevention, and rehabilitation. Some causes for hearing impairment: anatomic malformation, family history, low birth weight, ototoxic drugs, prolonged O2 administration, chronic ear infections, perinatal asphyxia, perinatal infections, cerebral palsy, and environmental noises. Like when we have the babies in an ICU, when they are extremely preterm, that we keep them in our kangaroos, our big old isolettes that are double walled, and it's not just to keep them warm and in a warm environment. It's also to try to prevent them from hearing so much of the beeping and the humming of the machines. Um, it gets loud in there. So pathology, hearing loss falls into two major categories. Conductive hearing loss occurs due to an interruption in the transmission of sound waves. That's from structural problems from the external or middle ear. Common causes are ear infections, injury, foreign bodies, and wax buildup, and it involves interference with loudness of sounds. Sensorineural neural hearing loss results from damage to the structures of the inner ear or auditory nerve from the congenital defects of the inner ear. Infection, ototoxic drugs, or noise pollution results in distortion of sound and problems comprehending sounds. Some children have mixed hearing loss, which combines the conductive and the sensorineural causes, interferes with transmission of sound in the middle ear and along the neural pathways. Central auditory interception is not linked to defects in conduction or sensorineural structures. It involves reception of auditory stimuli along the central pathways and expressing meaningful communication. It could be organic or functional. Organic would be caused by some sort of lesion. Functional, it'll be a non-organic lesion as the cause. The symptom severity, measured in decibels, a unit of loudness, and it's measured at varying frequencies. The hearing threshold is the critical listening speech range, and it has an effect on speech. Medical or surgical interventions depend on cause and type of hearing loss. If it's conductive, meds for otitis media. They're going to put some tubes in, or hearing aids, and acoustic feedback. A common problem, acoustic feedback, whistling sound the child cannot hear, so we have to readjust the hearing aid into the ear canal. And the sensorineural, cochlear implants bypasses inner ear hair cells and directly stimulates the auditory nerve fibers, sends signals straight to the brain. Multi-channeled implants are more sophisticated. They stimulate the auditory nerve in several locations with different signals and able to use pitch information. It's critical to identify, treat, and start rehabilitation within the first 3 to 6 months of life to improve education and language outcomes. We do hearing screens before the infant leaves the hospital. You're going to see these babies in the term nursery, and you're actually going to see some of those in NICU when you get an opportunity to go through there. If you have a baby that you're working with that's getting ready to discharge, all babies are going to go through a hearing screen. We have to know how they're doing if they're hearing. If the hearing screen, if they fail it, then we're going to have to refer them. So if identified as a hearing impaired, we'll notify the PCP. The parents are instructed to make an infant appointment for hearing evaluation by a specialist at that point. Signs and symptoms: infant does not or is not startled or blink with sudden loud sounds. They don't awaken by loud environmental noises. They don't respond to spoken word. They don't turn their head towards a sound by 3 or 4 months. Localized source of sound by 6 months. So you would expect them to be finding where mama's voice is coming from. Begin babbling by 7 months of age and respond by reacting to music around 8 months of age, or attempt to speak syllables such as da by age of 1 year. Profound deafness is likely to be diagnosed in infancy than a less severe hearing loss. If not detected in infancy, identified upon entry into school and may be mistaken for learning difficulties and disabilities. Primary importance is the effect on speech development and may have abnormalities in speech development related to the hearing impairment. So promoting communication. Lip reading It is important that we lip read, or that we speak right to them so that they can lip read. Cued speech, sign language. Encourage families to learn along with the child. It's easier than lip reading. Symbols help children learn faster. Speech language therapy, filling speech through multisensory approach. There's also additional aids, flashing light for phone, doorbell, and smoke detector to signal it's going off. Trained hearing dogs. We have, of course, some TTY or TDD telecommunication devices and closed captioning TV. Socialization. Children compensate very well. They're alert to surroundings and others. Hearing aids, the teacher may have to adjust their teaching style. They may have to go to a school for the deaf with others of like impairment. We need support of the child and family, and they may have issues of grief, require support, and refer to community resources. So care of the child during hospitalization, use the same principles as those for the lip reading on page 1095. Talk directly to your patients. Don't talk away from them. They need to see what you're saying. Ideal if parents can stay with the child to make them feel more comfortable. We want to reassess understanding of instructions given, supplement with any visual or tactile media, provide communication devices, make sure hearing aid is owned, picture board with common words, assistance of child life specialists. Those are trained professionals with expertise in helping children and their families overcome life's most challenging events. And Arkansas Children's Hospital is great with that. So preventative measures, chronic otitis media and respiratory infections increase the risk of hearing impairment. We have to treat it aggressively and check hearing periodically. Prenatal preventative measures, early prenatal care, genetic testing for any known familial disorders, avoidance of autotoxic drugs, especially during the first trimester, testing to rule out syphilis, rubella, or blood incompatibility. Maternal diabetes management, strict control of alcohol intake, and avoid smoking and smoke exposure. Adequate dietary intake during pregnancy. Make sure childhood immunizations are kept up to date to avoid possible central neural hearing loss from MMR and encephalitis. Use ear protection to avoid exposure to noise pollution such as target shooting or any other loud noises. Even household items such as lawnmowers and vacuum cleaners can pose a noise hazard. And a nursing alert, suspect a noise hazard if the listener has 1. Difficulty communicating while hearing the sound, 2. Ringing in the ears after exposure to the sound, or 3. Muffled hearing after leaving the sound. So visual impairment. Common problem during childhood. We need to start eye exams by 3 to 4 years old to detect and treat problems and prevent permanent vision loss. Critical visual development is between birth to 6 years of age. Excuse me. Until they can read, may use a Snell and E test, which may do the legs point, have the child point to the direction, or a shapes test. Children do not know any difference, so they don't know they can't see clearly. They will compensate by sitting close to the TV, cocking their heads a certain way, etc., to view whatever they're not trying to view. So school vision, partially sighted, acuity is 20/70 or 20 to 2200, excuse me. And that's education is usually okay in the public school system. With the legally blind, acuity 20/200 or poorer. It's not a medical diagnosis, but it's used to ascertain eligibility for programs, assistance, and tax status. What are the causes of visual impairment? It could be something prenatal or postnatal, infections, herpes, chlamydia, syphilis, rubella, toxoplasmosis, retinopathy, prematurity, trauma, postnatal infections such as meningitis, Other disorders: sickle cell disease, juvenile rheumatoid arthritis, Tay-Sachs, and retinoblastoma. You need to kind of breeze through the clinical manifestations and treatments. Those are found on page 3, box 37-6 on page 1098 to 1099. Refractive disorders, bending of light rays through the lens of the eyes, should fall directly on the retina. Myopia, the eyeball is too long, causing light rays to fall in front of the retina, so they have nearsightedness. In hyperopia, the eyeball is too short and causing light rays to fall beyond the retina, so the patient will have farsightedness. They can see objects at a distance but trouble with close vision. Treatment's going to be convex lens or laser surgery. Amblyopia is a lazy eye, so they're going to have reduced vision in one eye. Treatment's going to be patch the good eye to strengthen the lazy eye. That's not in your book, just FYI. Some other types of visual impairments: strabismus. It may or may not be refractive. They're cross-eyed children. Exotropia is inward deviation. Extropia, outward deviation. Transient is seen in infants less than 4 months old. It usually does resolve without treatment, but if it does not, they might need a referral to an ophthalmologist. Treatment is patch stronger the eye or possibly surgery to correct the eye muscle. And cataracts, opacity of the lens prevents lights from entering eye and refracting on the retina. Photo of infant with cataracts is due to rubella. You can see that on my slide, but you don't have it on yours. The treatment is surgery to remove the cloudy lens and replace the lens. Common causes of blindness in children: injuries to the eyeballs or anexa, penetrating sharp instruments, propulsive objects, firecrackers, guns, arrows, those kinds of things. Non-penetrating lacerations, blunt blows to the eyes or head, baseball, basketball, a fist, or burns. Treatment is going to be aimed at preventing further damage. Infections, conjunctivitis, may be viral or bacterial. They're red, inflamed conjunctiva, thick yellow, white, or green discharge. They'll have itchy eyes, burning eyes, blurred vision, sensitivity to light. It could be due to irritants as well as bacterial or viral diseases or allergies. These are some of the things that we're looking at for when infants are born: is did mama have herpes or gonorrhea? Treatment is going to be ophthalmic antibiotics. How do you administer? You have to administer eye ointment or drops. Systemic antibiotics in severe infections. Caution with use of steroids may exacerbate viral infections. And some infection control concerns. Very contagious because of rubbing the eye, then touching other objects. So the caregivers need to clean the eyes, and they need to avoid touching themselves, wash their hands quite often, spray everything down if they're in an environment where their siblings are there. Identify children who, by virtue of their history, are at risk for visual impairment. Observe for behaviors that indicate a vision loss. Screen all children for visual acuity. Nursing alert: suspect visual impairment in a child of any age whose pupils do not react to light. Critical visual development. Again, this is just I told you this earlier, birth to 6 years of age. Need to start the eye exams by 3 to 4 years of age to detect and treat problems and prevent permanent vision loss. And what are the signs and symptoms of eye strain and vision problems? Headache, sitting too close to the TV, unable to see the blackboard well, squinting, turning their head to the side, either side, trying to look at something. May have difficulty with schoolwork. So for care management, we want to promote parent-child attachment, Mom may feel child is not attaching by meeting her gaze when it is because the infant can't see. Promote the child's optimal development. We can refer them to community resources for help, the American Foundation for the Blind. Development and independence, help promote independence um, and self-care. Play and socialization, mainstream with sighted children. Education, schools for the blind may be necessary. Braille, audiobooks and learning materials. What about when the child is hospitalized that's visually impaired? We still have to provide a safe environment. Keep items picked up off the floor. Provide reassurance during all treatments. Explain strange noises. Orient the child to surroundings, where things are in the room, and then keep the furniture and other items in the same place. Don't go moving them around. Encourage independence. Describe placement of eating utensils on the tray to allow self-feeding. And treatment teams should be consistent. Speak to the child before touching them. Some preventative measures. Prenatal care, prevention of prematurity, rubella immunizations for all children, safety counseling for preventing eye injuries, preventing periodic screening of all children, parent teaching to comply with treatment for the disorder. What if they have hearing and visual impairment? Both visually and hearing impairment may have profound effects on a child's development. Motor milestones usually achieved, however, development may be delayed. Finger spelling into the child's hand and them into the other person's hand may help with communication. Developing future goals for the child, encouraged to learn to speak to enhance communication with others. Retinoblastoma. It is the most common congenital malignant intraocular tumor in children. There's 11 cases per million annually. Affects primarily children younger than 5 years. It's caused by genetic mutation or is inherited. Clinical manifestations of retinoblastoma. Most common side, there will be a white reflex in the pupil. Strabismus is the second most common side. Red, painful eye, often with glaucoma, is a late sign. They'll have severe permanent visual impairment, another late sign. The management, radiation, chemo, laser, inoculation, that's a removal of the eye. Photo on the left is, I want you to see this on here on my slide. The photo on the left is an infant with retinoblastoma, and the photo on the right is the same child with the left eye prosthetic. Survival rate is good at nearly 95%. Nursing home must have a high incidence of suspicion for this rare malignancy. Pay attention to photos and show a white eye reflex or parents reporting a white or strange light in their photos. Autism spectrum disorders. It's a complex neurodevelopmental disorder accompanied by intellectual and social alterations, verbal effects, repetitive, restrictive behavior patterns. 1 per 150 children are experience it, and it is 4 times as common in boys. Causes: genetic disorder of the prenatal and postnatal brain development. Immune and environmental factors may interact with genetic susceptibility. Relatively high risk of reoccurrence of ASDs in families with one affected child. Clinical manifestations and diagnostic evaluation. Peculiar and bizarre characteristics primarily in specific areas such as socialization, communication, behavior, difficulty with eye and body contact, and language delay. Diagnosis will be delayed until age 2 or 3 usually. Children with autism manifest a range of characteristics from mild form to severe form. Parents may notice early difficulty with eye contact, avoid body contact, language delay. Hallmark characteristic is the inability to maintain eye contact with another person. There is some diagnostic criteria for ASD. We typically do not, there's a new autism spectrum that we utilize now. And so when I say my son has Asperger's, that's a diagnosis, but he actually has, he would be diagnosed as a spectrum disorder. So, We in the past have identified these kind of children as they're autistic and what type of autism they're experiencing, but now I think we can just go across that spectrum there. All right, so it is prognosis. It can be severely a disabling condition with no cure. There could be some improvement with language skills that may be possible. Numerous therapies are used to recognize early. It's critical to implement proper treatment. Highly structured intensive behavior modification programs that focus on promoting positive reinforcement, increasing social awareness of others, teaching verbal communication, and decreasing unacceptable behaviors. Provide a structured routine for the child to follow is key in the management of ASD. Care management while in the hospital. Ideal if the parents can stay with the child. It's going to be their comfort level. Decreased stimulation in a private room is probably going to be necessary. Avoid unnecessary auditory and visual distractions. Personal possessions may lessen disruptive behavior, and keep physical contact to a minimum. Family support. Autism often becomes a family disease. Frequently, parents express guilt and shame. Stress importance of family counseling, community resources, Autism Society of America. Clients should be managed at home or in a long-term placement facility if necessary. See you in the classroom.